Hey guys, this is Vicky. I just want to take a few minutes and go over some slides in regards to communication, collaboration, and conflict resolution. As you can see here, this is one slide that kind of depicts the whole communication process. And not only is our reality maybe different than another person's reality, but how we interpret the messages can often be different as well. So we know that interpretation is influenced by many factors, some of which can include the context and environment, maybe such as the physical surrounding or potentially even emotional conditions, such as a patient dying, maybe a patient going through a very stressful moment, maybe precipitating events that prompt the communication. So maybe there was a recent argument or a heated debate. Maybe there are preconceived ideas such as concepts, opinions, or thoughts that are maybe developed from a different encounter. So maybe even a person is unkept and unclean, and we already start to have biases formed. We also know that there's a style of transmission that can either be open or closed statements, and also our body language definitely affects the way a sender and receiver communicate or interpret the communication. Our past experiences do definitely affect how we communicate and also how we take communication. And so it can either create a positive, neutral, or negative influence. Okay. And then, so if we think about that from a patient perspective, fully down. If someone was recently diagnosed with skin cancer, let's say that they're in the office and they're diagnosed with skin cancer, maybe one of their parents just died from colon cancer. So the new diagnosis of skin cancer may take on a completely different meaning because of the past experiences that person may have had. And then personal perception is everything that the person knows about the situation. Um, if they don't really understand anything about the situation, then they may not understand what is really being said. So all I'm trying to say here is that when we communicate and we verbally or non-verbally speak to another person, we do have to remember that there are many things going on than just the communication. There's many things that influence a person's ability to understand, comprehend, and make decisions. Oh. This is just a little thing that you can take a look at. But let's take a look at our perception. So we know that a perception is really our view of the world, and it's influenced by a number of factors. Some of them that are listed for sure are values, our beliefs, our culture, our social background, and for sure our interests. If we think, I'm trying to think of an example, but well, we'll just leave it at that. So know that an individual's perception does depend on their lifestyle and what they bring with them. Next, we want to take a look at both verbal and nonverbal communication. So we know that the verbal communication is really the tone or inflection with the words that are being used, or the general attitude used when speaking. So the attitude that accompanies verbal interaction is more meaningful usually than the words spoken, and it can either be positive or negative. Attitude is also communicated loud and clear through nonverbal cues that can be intentional and deliberate, or potentially unconscious and non-intentional. If you begin to watch people, you really can pick up on a lot more nonverbal communication that's really done unintentionally. I know that when I start to get annoyed or irritated, people have told me that I do certain characteristics, and I guess I didn't even really notice it until somebody started picking up on it. and telling me about it. So what I would suggest is have somebody watch you for a while, have a close friend watch you and talk to you about some of the non-verbal behaviors that you exhibit. I think that you'll be pleasantly surprised that you really do quite a few non-intentional, non-verbal communication styles that do affect the message that you're putting out there. But some of the nonverbal direct messages include facial expressions, and a lot of times we'll have maybe a smile, a raised eyebrow. Sometimes people can not or avoid eye contact if they're, not wanting to talk to you. Maybe that open or closed posture, so maybe their arms, if they're open, are kind of at their side, or closed, maybe they're a little bit more guarded and their arms are crossed. We also, there's a lot of, usually, there can be at least eye rolling with nonverbal cues. And then we have indirect messages, which are really our dressing style, our lifestyle, and our material possessions. So indirect nonverbal cues can be preconceived ideas because of a person's dressing style, lifestyle, or possessions. So example, if a physician makes a round on a Saturday morning in maybe shorts, t-shirts, and flip-flops because he's going to play golf afterwards, what message does that really bring to the patients and family versus wearing the formal professional white coat and suit? It does bring on a much different perspective, and how does the family going to view that and reflect that? So like I said, what I want you to do is take a moment and kind of answer these questions. Do you have, what's really going on with your verbal and nonverbal communication? What type of direct messages and indirect messages do you have that you know of, and which direct and indirect messages can other people pick up on that you may not know of them? I think it's just a good idea to have some of that information in tow so that you can work on some of those. So again, both back on that nonverbal communication, we have both facial expressions, and they're very important. So smiling, showing empathy, using questions when appropriate. Establishing eye contact really says, what you are saying is important to me. So it's very important. The inability to make direct eye contact during communication can potentially be perceived as being shy, scared, or not even telling the truth. But do be aware that in some cultures, direct eye contact is avoided if possible. So it may not be one of those three preconceived ideas. It may potentially be that it is their culture. And then when we think of our posture, we know that open posture is, holding the arms at the side or out to another person and leaning in towards the person you're speaking to. But when we have open posture, we do have to remember that we need to observe and be cognizant of people's personal space and how how close that personal space is and how that makes them feel. Some people are okay with hugs and touching, other people are not. And even in different environments, within the mental health environment, one has to be very careful with personal space and touching. Now, on the other hand, we have closed posture, and obviously we talked about that already, but it's kind of closing your arms and leaning really away from a person. And we know that this kind of may potentially shut down a conversation, so we want to make sure or put off that we're upset or angry, or don't want to, like I said, talk with a person. So just be careful with using a closed posture technique. However, what I do find is that a lot of people, just for comfort's sake, will, and I do this, I hold my arms, I fold them across from each other, and that's how I stand frequently. So just be aware of that, especially when you're talking with family members, what type of posture you have. Oops, shoot. All right, when we think about listening, So listening is probably, I believe, one of the most important parts of communication. If we as nurses are not good listeners, we are going to miss out on many things, not only in the context of our patient's condition, symptoms, and picking up on different treatment modalities, or potentially even what's going on with the patient, but if we're not listening to our peers, our other nurses, the providers, we may be missing out on very important um, information that we need to be able to care for a patient correctly and safely. So within this week's Blackboard, there is information on SBAR, and I want you to make sure that you watch that video that's in there. So when we think about listening, these are the main components that I want to make sure that you're looking at. Is make sure that you're framing your answer. You pre-existing concerns are addressed, because oftentimes pre-existing concerns or emotional reactions can block part of the conversation, because if your mind is wandering, that's really all you're thinking about is the pre-existing concerns. Now, as a nurse, if I have a concern with a patient, oftentimes I will write it down, because otherwise what will happen is the whole time the provider is talking to me, I will be thinking about the concern or the issue that I need to address with the provider, and I may block out or tune out all of the other important things that the provider is telling me. I do instruct the patients to do the same thing. If the patient has something that they want to make sure that they're speaking to the provider about, and the provider isn't going to be around until later in the afternoon, I strongly encourage them to write down their concerns or what they want to have addressed with the provider, so that throughout the day their mind is able to continue to think about other things, and when the provider is then in front of them, they don't forget or they don't concentrate solely on making sure that they've addressed those pre-existing concerns. So when we have our purposeful steps, hearing, the three purposeful steps for listening correctly really include hearing. So listening enough to know what is being said, understanding, so processing the information so that one really has a good idea of what the person is saying and what that really means and where I need to go with that information, and then judging, so making a decision about what you've heard. So you hear it, you understand it, you judge it, and you make a decision about what is the next step that needs to occur. When we think about positive techniques for active listening, we think of these three bullets. So giving your undivided attention to the sender. I find that most frequently this is missed. It's not uncommon for a nurse to be trying to do multitasking, doing different things when a patient is speaking, or potentially even when the provider is speaking. Now, what I want you to think about is, what if that was you? What if you were the sender and I was the receiving nurse getting the information? How would that make you feel if I didn't give you my undivided attention, if you were speaking to me about something important? You may not feel important if I'm cleaning your room, if I'm, fiddling with a dressing change on you. So making sure that when a patient is talking to you about something serious, or a provider is talking to you about something serious, that you take the time, give them your full undivided attention, give them the eye contact they need. Many times I say that the best way to listen is to be at their level, and that is part of the nonverbal communication. I feel that is very important. It's not uncommon for me to not only have an open posture, but also to be at the same level as the patient. Don't be peering down over them. Sit on the chair. A lot of times I know that we tell you not to really sit on the bed, but many times if the bed is clean, if I know that it's clean, it just got changed, I will sit on the bed, touch the patient's hand and listen to them. and give them my undivided attention at their level. That is the most comfortable that they're going to feel. If you think about your nursing experience in nursing school, and when a nursing instructor stands hovering above you, you feel pressured, you feel anxious. It's really no different for a patient. The same is true when you're talking to a provider. If the provider is standing, stand. If they're sitting, I guess if you want to stand over them, if the chair's available, sit down to talk with them. It will bring a different environment to the communication style that's occurring. So back to the positive techniques, making sure you provide feedback. Sometimes this can be by rephrasing in your own words, and by rephrasing you're ensuring that you've listened to the message, that you understood the message, and that the decision that you're making about the message that's being sent is accurate. And then always being aware of the nonverbal messages that not only your body and eye contact is giving off, but also what the receiver is giving off, because that can change the context of the communication style as well. Let's think about written communication. So we know that nurses use a lot of written communication, especially in our charting, whether it's a DAR note, a DAP note. We use many memos in the hospital. We also use emails, incident reports, maybe different discharge forms, teaching forms, and definitely in shift reports, and even on our what we call our brain sheet. And so what you have to remember, that even if it is a brain sheet and it's really mainly going to be your sheet, you still want it to be as accurate and have the most important information that's concise, descriptive, and truthful. Now, although your nursing brain sheet is not going to be considered part of the medical record, could it potentially be given to another nurse if you go on break? It definitely could be. It's not uncommon when I would work on the floor for me to not only give a verbal report, but also hand them my brain sheet and point out different areas, because there's no way that they would be able to remember 4 patients when I was gone for a half an hour. So making sure that all of our written communication is timely, concise, and descriptive is very important. So attention should really be paid to both the detail and the thoroughness. We must be descriptive and also complete or kind of create that mental image of what's really going on. And I especially say that when we're documenting our DAR notes, DAP notes, whatever the facility uses for creating the chart notes, or the notes about charting by exception, things like that. The idea of written communication really is to encapsulate what you saw, what you did, what the patient experienced, and what you did about it, to ensure that the patient was in a better situation after your nursing interventions were completed. Now, when we think about obviously concise, right, we want to be clear and brief and use pertinent information. Many times I see that nursing students will write a note, and within that note, let's say it's a cardiac note. In the note, I'll find things on GI, bowels, pain that's not related to cardiac. When you're writing those notes, you want to be as concise and brief but to the point as possible, so that the next person, if they know they're looking for something cardiac, a cardiac event that went, they can go right there, understand, the patient went into atrial fibrillation, became hypotensive, started amiodarone, whatever it is, whatever the note needs to say, but including everything and writing these big long narrative notes in most cases is not pertinent. And then when we think about electronic communication, especially nowadays, we're using more emails and also charting within an electronic medical record. First and foremost, I think the biggest thing is make sure that you're spelling correctly. I can't tell you how many times I've read notes by nurses in which communication or spelling is not correct. Now you have to think that you are not only representing nursing, but you're representing yourself. And when the next provider, whether that's a nurse practitioner, a physician, a dietitian, a respiratory therapist, reads that note, they are forming a judgment about you because you can't spell very well. So please use the spell check in the computer charting. Also know that capitalization usually means shouting. So try not to use capitalization of the whole word, and that symbols do express emotion, but for the most part, symbols should not be used in a medical record. One thing I do say is make sure that before you hit submit in any of your electronic charting emails, is make sure that you reread it. And if it is an emotional one, let's say you're sending an email to a colleague because you're upset about something, I strongly encourage you to save it. Think about it and go back maybe the next day, reread it, and make sure that before you send it, it is exactly what you want it to say, and it's coming across in a professional manner. All right, and then lastly on this slide is telephone etiquette. So what I find most frequently is that nobody wants to pick up the phone. So first off, you have to pick up the phone when you're at the hospital. When you become a nurse and you find the unit, whether that's in the hospital, the nursing home, outpatient services, the clinic, make sure that you do take the time to please pick up the phone. There's obviously somebody who needs something on the other end of that, and yes, will it slow your day down? It might. But could it be lab calling about a critical lab? Could it be, if you're working on medical and you have a decentralized telemetry system, could it be the monitor tech telling you your patient went into VTAC or atrial fib? It definitely could be. So it's important to make sure that all telephone calls are treated just as importantly, because it could be that your patient is in dire need of medical attention. Otherwise, if it's just normal telephone talk, make sure that sometimes individuals speak super fast when they're on the telephone, so make sure that you speak slowly and distinctly, meaning that the person on the other end is going to be able to understand you. Make sure that you allow time for the other person to process and ask questions even when they're on the phone. So the communication process shouldn't differ whether it's on the phone or face to face. If you are leaving a voicemail, and it is about, I would caution you about leaving voicemails for individuals if it is regarding health conditions, labs, things like that, because of HIPAA. You do not know who is going to pick up that voicemail on the other end. So I would ensure that you look to your agency's policies and procedures regarding leaving voicemail about medical conditions, appointments, things like that. So we know that there are different communication styles. Assertive people usually state their wants, needs, desires, and feelings using oftentimes objective, direct comments, usually without violating the rights of others. And assertive individuals are responsible for their actions and what they say. Now, non-assertive people are usually timid, a little bit more timid, have reserved behaviors, and do what others tell them to do without questioning what is best for them. Now, on the other hand, aggressive communication style or aggressive individuals are usually commanding, dominant, and use superior words to make accusations that violate the rights and well-being of others. Assertive communication style is not one that you want to emulate. Aggressive communication style is not a communication style that you want to emulate. You want to be an assertive communicator, especially when you are the charge of your nursing team. Like I said, you need to be able to define and communicate your wants, needs, and desires for the nursing team, for the patients that you're caring for, without being aggressive. If you become aggressive, you are going to put people, not only the people you're working with, but also the patients on edge. And maybe even at times, they may not want to even work with you just because of the attitude that you're possessing. Then we have active communication, and that's really participating in the conversation, um, actively engaging, actively moving the communication forward. And passive, though, is more non-participation of people. And so if you go back, they're kind of like those fence sitters with change. They're kind of the same thing with communication. They're often influenced and acted upon after they see others. So when we look at the assertive nurse, this is really where you want to be in your nursing career. The assertive nurse appears self-confident and composed. She or he definitely maintains eye contact with both or either the patient or the provider or another nursing peer. She or he uses clear and direct communication to ensure that his or her message is being communicated clearly and effectively. She or he makes sure that they speak firmly and positively, speaks genuine and without sarcasm, is non-apologetic. Took me a moment, it's in the morning. Takes initiative to guide the situation and really understand what's going on. So it's not only about just getting your needs met, but it's also listening to the context of the message between you and the sender, between the sender and the receiver, because we have to ensure that we understand what is going on with the other individual if the communication or if the things that you're asking for are not getting done correctly or timely. And then ensuring that you're conveying the same message both verbally and with your nonverbal communication styles. So one thing that there is a fine line between assertiveness and aggressive behavior. Assertive behavior, remember, expresses thoughts and feelings while respecting others, whereas aggressive behavior does not. Aggressive behavior is often used to humiliate, dominate, control, or embarrass the other person. Maybe examples could be being rude, belittling, screaming, sarcasm, or maybe even using personal insults um, to manipulate the situation so that the individual gets what he or she wants. And so the goals are at the expense of others. So aggressive behavior is not a communication style that you want to have. And so you have to be careful, especially when you get in a heated moment and when things need to get done quickly or efficiently, and you need to be able to communicate that information without being aggressive. Oops, there we go. Okay, so for crucial conversations, I do want you to take a look at the 7 crucial conversations, because these do affect conversation. So broken rules, mistakes, lack of support, incompetence, poor teamwork, disrespect, and micromanagement are the 7 crucial conversations that if healthcares fail to have, they probably do add to unacceptable behaviors, communication styles, and most certainly errors that can occur. You know, some coworkers take shortcuts. We also know that can endanger patients. Um, so they have poor clinical judgment, maybe are more reluctant to help, maybe are incompetent, gossip, maybe inform cliques, are condescending, insulting, and rude, and abuse their authority. So when we find that we have coworkers who are disgruntled, it is important, I believe, to address that, ask them what's going on, maybe they just need help for the day, maybe they're feeling stressed, but it is important to be a good team player and making sure that we address the areas of incompetence and disrespect or lack of teamwork as a whole. So why don't we speak up? Well, we often don't speak up because confronting people is difficult, right? It's really hard to go up to someone and say, hey, Sally, I noticed today that you're not helping out and that your work isn't getting done and you're disrespecting the team. Why? Right? That's really difficult for all nurses, for really anybody to do. However, if we don't speak up and we don't confront the behavior that we see, we're really supporting it. And it's easier then for the next person to, or for that same person to repeat that behavior over and over again. And at whose expense is that? It's at the expense of the peers, it's at the expense of the patients, it's at the expense of the providers. Everybody is getting the wrath of that patient. If we don't speak up and if we don't confront behavior, change will never occur. Other reasons, maybe it's not my job. It is your job. You are part of a nursing team, and to be a cohesive member of the team, it's important to address all behaviors. Like I said, some of us may have low confidence, and I can definitely see that. When you become a new nurse, you won't have the confidence, you won't know the people very well to be able to address some of the behaviors. But as time grows and as your confidence grows, I think it is important that you address different behaviors rather than just run to the director or supervisor. And then there's always the fear of retaliation. So if I go and talk to Sally, will Sally make my next couple shifts terrible? And is that a possibility? It's a possibility. But if you don't ever say anything, then you're not trying to be the change agent that I know that you can be. And if retaliation does occur, that's when you speak up again. If it gets to be the point in which retaliation is gotten extreme, that's when the director and supervisor need to be aware of what's going on the unit. And then last thing is reporting incidents. So reporting incidents, or incident reporting, is a legal responsibility for nurses. All facilities have incident reports that typically go to the risk management person, and this risk management person or team does analyze it and review it to ensure that that incident does not repeat itself. So they trend them and look at them to ensure that it won't happen again. Some examples of common incident reports that are reported include medication errors, patient or staff injuries, and equipment failures. But it's no different. This is a written document, so you need to ensure that you use correct written communication techniques when creating the incident report. Now, when we think about communication and an effective team work, we know that collaboration is essential, and we know that we can get a lot more done through collaboration, and that teamwork is best done through collaboration. So it's a partnership approach that relies on an open exchange of information. It is dependent on mutual respect, and it's a social skill that involves working together with two or more persons. Every day that you're going to work as a nurse, you are going to be collaborating. Whether you're going to be collaborating with other nurses, the providers you're going to be collaborating with to ensure that the nursing interventions and the patient's medical treatment are correct. You're also going to be collaborating with your CNAs or medical assistants to ensure all of the patient's ADLs are being met, they're being walked, things like that. So collaboration is essential for effective team work. So when we're communicating within our collaboration, some of the major important things to do during collaboration is defining the common goal, right, and using common language. All the members on the team have to be communicated, what is our end goal, what are we striving to do today, and making sure that we're providing mutual respect to all the members on the team by sharing knowledge and expertise to all of the parties, and making sure, like I said, that they understand what needs to occur. We need to make sure that our communication is open and honest, that we're following up on delegated tasks, that we're clarifying any misconceptions or misunderstandings, or if there's not common language, if you're working with a CNA or a medical assistant who's not from the area you are, abbreviations may not be clear. So it's making sure that the person has a clear understanding of what will occur that day. Collaboration is also most effective when we have shared decision-making powers. So the CNA, the MA, another nurse, you have to remember that your way is not always the best way. And it's okay as long as it's not endangering the safety of the patient or the safety of others in the area. We also want to offer support to all parties involved, so making sure that we follow up, giving the, hey, that's a great job today, or you know what, we really worked well today. So providing that effective verbal communication to cheer them on is really important. In healthcare, and I think in any business, it's very easy to focus on the negatives. However, we have to be providing support and giving the attaboys to all the people that are on our team so that we work cohesively together as a team. And then the last point, there's mutually accepted roles is definitely a must when collaborating. So when we think of interdisciplinary team members, many facilities are now having interdisciplinary rounding, which means that coordinating patient care is really occurring across a multi-professional approach. And this collaboration is what really pushes evidence-based practice and care and ensuring that the patient is receiving everything he or she needs on a holistic perspective. So common members of the interdisciplinary team can include nurses, physicians, pharmacists, therapists, dietitians, social workers, the respiratory therapist. Oftentimes even the hospital supervisor, nursing supervisor will be involved so that he or she has a better understanding of what's really going on the unit. Most times the multidisciplinary or interdisciplinary team will meet in the morning, and they will typically go through all of the patients and ensure that their needs are being met. And if not, what is the plan for them for that day, for that admission, so on and so forth. Now, on the other hand, we have a multi-professional team, and this can include therapies and fitness centers, county and school programs, along with hospice, home care, and the Commission on Aging. All right, so that ends our lecture on communication. If you have any questions, please let me know.